All right, we would like to welcome everybody to Grand Rounds today. We're looking forward to hearing from Dr. Wood today. He is, Dr. Wood graduated from honors from Harvard University, completed medical school, residency, and fellowship at UCLA. He is board certified in pediatrics and preventative medicine and public health, and completed a health services research fellowship at RAND UCLA. He is currently a tenured professor and Chair, Department of Pediatrics at ETSU. For more than 20 years, his research and advocacy efforts have focused on improving health systems for underserved children and adults. He has published more than 150 peer-reviewed publications, reports, and book chapters. He founded and directed the Jacksonville Health and Transition Services, JAXHATS, program until late 2014. Since its inception, JAXHATS has received continuous funding from the Florida Title V program and has served approximately 1,000 youth, providing a patient-centered medical home to medically complex and developmentally disabled young adults. Dr. Wood helped create and was the medical director of Florida HATS, the Florida Office of Healthcare Transition. Dr. Wood has been active in advocacy for disadvantaged children and adults, with a focus on children and adults with IDD, serving as a gubernatorial appointee to the Florida Developmental Disabilities Council for over 12 years. In his current position, Dr. Wood is working with ETSU, Mountain States Health Alliance, and other community partners to build a system of care for children, for all children in Middle Appalachia, an area that includes Northeast Tennessee and Southwest Virginia. We're grateful to have him here to speak with us today.
Well, thank you. I got to shorten that bio. That's too long. But appreciate the opportunity as a pediatrician to address psychiatrists. This is kind of fun, right? So I am a general pediatrician. I'm hoping that soon with Kiana Johnson, she's a junior faculty with us here in pediatrics, that we'll be able to start a transition program here in this region. A lot of other issues have kind of taken my attention with the department, but we're really focusing this year on trying to get something similar. But as you so graciously read, Dave, the program that I started is still going on. In this program, I won't show you data from it, but we had a lot of youth with mental health issues. Mostly they would come to us with comorbid other conditions. And a lot, we had probably a couple, at any one time, 200 or 300 youth and young adults with intellectual disabilities, which then would have co-occurring mental health and behavioral disorders. But then we had other youth that would just, I can go as we talk about youth, but youth from foster care, youth from juvenile justice would come into our clinic to help get transition. They would usually have a chronic condition in addition to that, but we had a fair amount of experience kind of working with youth. Anyway, we're going to hope to kind of cover, so I'm not a mental health services provider, and my understanding of the mental health services system is always, I'm very perplexed by it. But so I'm not an expert in that. But what I can share with you is some of the general aspects of transition that are, oops, I don't have any. I also like Larson cartoons. But as I get older, this is more of a reality for me, you know. But what I hope to cover is, you know, just defining healthcare transition, understand what it is, how do youth with mental health disorders fare during transition, and unfortunately, the bottom line is very badly, very, very badly. So what are the factors impacting them, and what are some practical ways we can improve transition of youth with mental health disorders? So the first good news is all children, there's a 90% survival rate of all children now, even with very serious chronic illness. So they become adults, but we have very limited planning to make this happen. Some of the bad news is they have to go through stages that can be very challenging to work with, as I'm sure many of you know. I like this slide about healthcare transition. It kind of breaks it into three different components: of kind of preparation, the actual transfer from pediatric care to adult care, and then like we call it here, successful transition, which really means integrating into the adult health system. And as you can imagine, regardless of what we do here, when I go over all the different challenges, even if we do have a transfer, which often doesn't even happen, usually it's just a goodbye, go find something. Oftentimes, after they do not successfully engage in the adult health or mental health system, and we'll talk about that. So, a little bit about the epidemiology. Again, I'm preaching to the expert group here, but mental health disorders in children is much more prevalent than most people recognize, and even more serious ones. But we have about 3 million youth that are transitioning every year, and it just shows that if 17 to 22% have some type of disorder, we have lots of youth with mental health conditions that we're trying in pediatrics to hand off to adult services. And I think the main lesson from this talk is if there isn't a coordinated effort to do that, it probably won't be successful. These, some of the data from, that are longitudinal data show that mental health conditions in children are increasing in incidence and prevalence, and just, suicide is a major issue in this particular group. This is some data from National Survey of Children's Health. So this is self-reported data, but this is for Tennessee, and you can see how many youth. This is across all of childhood, what the prevalence is of these different conditions. When you start drilling down into our population in Northeast Tennessee, we're about 8% of all of Tennessee. There's 300 or 400 youth with each of these conditions per year transitioning out of pediatric care or out of child mental health care. I mean, that's a lot. I mean, do we have a system to manage that? So that's just something to think about. There is a huge split, as you probably know. I mean, how many are residents? Where are you residents? They're the residents, yay. Any child psychiatrists here? Child and adolescent psychiatrists? Okay. Adult psychiatrists? Okay. Psychologists? So you guys know that the pediatric mental or child mental health system and the adult mental health system oftentimes don't communicate well. And there is this big split. But that's actually true of specialty care in pediatrics generally. If you look at children with inflammatory bowel disease, you can pick any chronic disabling condition. Is there a good handoff between pediatric specialty care and adult specialty care? And the answer is, unless there's a special program for that, the answer is no. There are conditions that particularly are challenging for transition, like intellectual disability or cerebral palsy, which have high rates of co-occurring mental health conditions. So, but almost every major condition, there have been efforts in cardiology to train adults, cardiologists to care for adults with congenital heart disease. There are actually more adults with congenital heart disease than there are kids with congenital heart disease. There's more adults with cerebral palsy than there are kids with cerebral palsy. And there's certainly many more adults with mental illness, but this transition through from childhood to adulthood, in our health systems we have kind of a big chasm between pediatric care and adult care. And it's been raised in many reports. This is the White House report, which is saying that this specific group, this age group, sometimes we call it the emerging adulthood. They're late adolescence into early adulthood, 18 to 24, 18 to 29. There needs to be a special emphasis on that group because they have different kinds of needs than children and they have different kinds of needs than older adults. This is just a very, very, very busy slide. I tried to make it a little more intelligible by putting red blocks on there. But this is synthesized data from a number of studies, including the Smoky Mountain mental health study, a couple of studies in New Zealand, following youth into adulthood and looking for persistence of diagnoses. And you can see from this that the basic bottom line to this is if a child has a mental health condition in adolescence, they're very high likelihood of having something in adulthood. It may not be the same diagnosis. They may have anxiety, depression in adolescence and then move into a substance use disorder or some other kind of condition. But this is basically saying if you have anxiety, and they're adjusting for, unadjusted means just raw rates, but the adjusted is adjusting for co-occurring illness. So if you have anxiety, you know, you're more likely, it's borderline, more likely to have anxiety as an adult. If you have depression, you're more likely to have a conduct disorder as an adult, or a substance use disorder, and more likely to have any diagnosis. So ADHD is interesting in that if you have ADHD as a youth, you're very likely to continue to have ADHD as an adult and have oppositional defiant disorder. And ODD is very likely to continue into adulthood. So these conditions continue into adulthood. They start in adolescence. One statistic is 75% of mental illness in adults starts in adolescence. But I don't see our health system organized the way to address that, to provide services that are adolescent friendly, to make sure that they get good services early, so to prevent the long-term effects. And this is basically a nice little diagram on life course. And life course, so in pediatrics, we think about a developmental trajectory. In adulthood, you're kind of on in adulthood, you're basically stable or status quo, and then you start to decline. So in healthcare, we try and prevent or maintain the current health. And when they get into the age that I'm getting into, 60s, we're trying to prevent decline or support the decline. But in pediatrics, they're developing and they're accelerating. And if they get protective factors, that development will be enhanced. But if they have risk factors like poverty or family disruption or sexual abuse or neglect, parental discord or violence in the home, all these things cause the trajectory of that use to go down dramatically. This is way beyond the topic here, but you know, we're going to have next week actually Andy Garner Monday night. I would encourage you to come Monday night at the what's the name of the College of Medicine building? I just went blank. Stanton Gerber, thanks. So over in Stanton Gerber, we're going to have an expert, a neuroscientist, and a pediatrician who's talking about early brain development. And I'll talk a little bit later, but you know, brain development is going on into the 20s and late 20s. And so if we have optimal, you know, mental health care, if we have healthy families, then children will develop and grow into adults that are healthy. But if we don't have healthy families and lack of services to help address the issues, then that trajectory is going to be impaired and we'll have unhealthy, impaired adults. So there's lots of factors that complicate mental health care for youth and young adults. That YYA is youth and young adults. And you can see them and you know about it. This is a very difficult age. I'll go more into what the challenges are in this age of, you know, and the age we're talking about is like 14 to mid to late 20s. So they have high rates of poverty. They're some of the poorest folks in the country. When you look at by age poverty rates, they have, when you have co-occurring mental health conditions, they have low rates of education, lots of substance use, and a lot of disruptions like involvement with the criminal justice system, juvenile justice, or homelessness, and foster care. Those are the big service systems for youth that you guys interact with in mental health. It tremendously complicates providing services to this population because of all the disruptions that they have, not only in their life, but to their health care delivery. There are these, during this period of time, this adolescent, young adult period, there are these what we call service tunnels. Youth tend to, with mental health problems, tend to stream into these tunnels, and you know about them. In foster care, if they put in foster care and they stay in foster care, then they may go into a foster care transition program. Unfortunately, we've had funding for the last 10 or 15 years. Tennessee has a very active program of trying to help youth that age out of foster care stay engaged. I mean, the data on youth exiting foster care is abysmal. You know, over half become homeless, addiction disorders, all kinds of things. But the new programs are trying to engage them with supported housing and keep them in education. And currently in Tennessee, about 50% of the youth that leave foster care stay in these transition programs, which is actually better than before. Juvenile justice, if they get in the juvenile justice system, they probably transition to the adult penal system. Special ed, this is again youth with co-occurring mental health disorders, but they also have learning disorders. They are in special education, and then they get involved in transition programs in the schools and into vocational and rehabilitation programs. And then just your average child who has a mental health condition that's getting care in the system of children's services then transitions to adult services. But these are very complex systems to interact with. In Jacksonville, we worked for years to try and work with foster care and juvenile justice so that we could identify the youth that had the more significant health and mental health disorders. Very complex systems to work with. We had moderate success doing that. So why is this healthcare transition, episode or time of life important? You can see what happens, and I'll go into detail about these things that happen during this time. But it's really quite a volatile time, lots of changes, but a lot of system changes, insurance and other things. And I'll really go into some more detail on some of these things. Some of the data on youth with mental health disorders is pretty discouraging, but also data on youth with chronic disease is discouraging in this. In pediatrics, we spend a lot of money and helping youth with, say, a renal transplant or congenital heart disease. And then during this period of transition, their adherence goes down. Their access to care goes down. And a lot of times they suffer really significant morbidity or early mortality. Diabetes is a great model that needs constant daily attention, and the data show that as youth go through this transition period, there's many factors, and I'll go into some of them, but their hemoglobin A1Cs go up dramatically. This is an interesting sample of a survey of child and adolescent well-being. It was done from a sample in northern New York, and they followed youth for about 10 years into adulthood. They used the diagnostic screening tool to identify people with mental health conditions, and about 50% of the cohort reported mental health conditions. This is a pretty busy slide. I should have put my little red circles on here. But what you can see is visits basically to the community health center. This is a baseline, I'm sorry. This is 1.5 year, 3-year follow-up and 5 to 6 year follow-up. You can see that basically use of health services goes down, down, down as they get older. As they go through this is again, they capture them about 12 to 15 years of age, and then they follow them into the early 20s, and help from a psychiatrist, 32%, 18%, 14%, 8.6%. So you can see that their utilization of services just goes down fairly dramatically during this age grouping. This is kind of a graphic representation of that, showing outpatient visits going down during this age group, 16 to 17, 18 to 19. This is residential treatment, goes down dramatically, 100% decline, because once you hit 18, it's very hard, unless you have intellectual disabilities, to get residential treatment, even if you have, a very severe mental health disorder. So some of these services, part of this big gap in transition is that services change when you get to be adult, and things that are available to you as children are not available to you as an adult. As a matter of fact, I got a call from someone who wanted to. Their daughter is an adopted child. She had very significant, fetal alcohol syndrome, very significant behavioral, very aggressive. She was under psychiatric care, and mom was just at her wit's end, and someone put her in contact, someone put her in contact with me, and I was trying to help her. But this girl was 20 and had an IQ of 78, and it's really hard to find anything. If she had an IQ of 58, it would have been easier to find something. So the service delivery system is quite complex, and you see great drops in utilization. And you know that these youth, their mental health status is not changing that much as they get older. again, this was this young adults in community health study. You can see that any psychiatric disorder was 18.2%, 9% had multiple. You can see the kinds of disorders. They followed them. This was an older study, but they used a very standard diagnostic interview. They followed them, and they looked at their outcomes, and so did not complete high school. If you had a psychiatric disorder, almost 2 out of 5 did not complete high school. No gainful activity, criminal involvement, ever pregnant, sexually active. That was the only one that wasn't different between the no psychiatric disorders because they had about the same rate of sexual activity. But all these other outcomes for youth with mental health disorders are pretty bad. I mean, high rates of really significant failure. They looked across a number of studies that followed youth with mental health disorders across this adolescent young adult period. And I just put a box around. These are the outcomes: secondary school completion. These are the general U.S. population rates of secondary school completion. You can see that the youth, they vary somewhat by the different studies, but generally speaking, secondary school completion, current youth employment, residing with family, recent criminal involvement, and pregnancy are much higher for this population with mental health disorders. So what kinds of things, other things besides, there's lots of factors affecting healthcare transition, and I want to go through some of them. This is one of my favorite slides. It says, first they make you button your shirt, then they make you tie your own shoes. You got to ask yourself, where's this all going? And in adolescence, in our clinic, we were trying to train adolescents to be independent. And so that's really challenging them, asking them to tie their own shoes in a way. So part of healthcare transition is getting them to take more responsibility for their health and healthcare, to stay on their meds, if they're supposed to be on meds, to come to visits, know how to do this. And so that's a big part of healthcare transition. But there are a lot of factors impacting them, and it's a little bit overwhelming, but we'll go through some of these different factors just to quickly show you. There's some very interesting secular trends in our country in terms of education in youth, marital status. So the bottom line is that, the 20s is the old teens, I guess. So kids that used to graduate from high school in the 40s, very few went to college. You can see 14%, I'm pointing to the wrong place, 14% went to college in the 40s. Now 60% go to some kind of college, maybe junior college, and maybe off and on with work, mixed paths. But there are really a lot more continuing education. People are delaying marriage. People are living together, but they're getting married later. And this has really increased the length of transition. So now there's really a new kind of stage in life that they were proposing called emerging adulthood. And emerging adulthood, I'll go a little more into this, is late adolescence into early adulthood. And there's some definitions about this, about early adulthood, emerging adulthood. And, this is a study from Clark University. Basically, they asked people in this age group, what does it mean to be an adult? And so these are the things, basically these are the milestones that young adults in this age room, late teens to early and late 20s, said. It has to do with independence, being financially independent, interdependence with relationships, long-term stable relationships, role transformation, having children, getting married, pursuing a career, and norm compliance, really going through the period where you're doing high-risk behaviors, and that's settling down. So when you stop doing these things, this is one marker. I like this slide because it just shows all the different things that are going on. I mean, people that are 18 are basically with their family, not married, do not have stable employment, and by the time they're late 20s or early 30s, they're usually independent, married, or in a relationship, and have some kind of a career. So these are huge changes going on. And the big, developmental stages are leaving parents to go be with peers and to start romantic relationships. And this is, the Piaget's formulation of basically intellectual development of adolescence, from concrete thought to abstract thought to formal abstract thought. And this is really critical. I'm sure you see this if you take care of youth, really a critical aspect of a transition for youth. If a youth is in concrete thought, that means they're really not thinking about consequences. They're not thinking about the future. Nothing really matters in the future. And so if I do something bad now, there really are no consequences. So trying to convince someone that they need to stay on their medicine, because if they don't go on their medicine, they're going to have to be hospitalized again, that doesn't really make sense if they're in concrete thought. So it's this development of their cognitive processes that helps them start to take more responsibility for their health. This is a kind of a cute slide that just shows myelination of the brain from from the back to the front and the forebrain and the frontal lobes being myelinated late. This has been now big in the press about adolescent brain development and executive functioning being very late. And it really ties into this secular trend, too, of what we expect from people. So it's not just brain development, but it's also their brain interacting with our society on what roles are expected, when you take responsibility. But we do see, later development of executive functioning. That's when formal operations can take over. It has a lot to do with then whether they're going to be compliant or adherent with the recommendations that we make as healthcare providers. So I put down a few that I dealt with in my clinic. You can read them. But, I had one young woman, we debated whether or not she needed a depot shot, and she was kind of pretty much in concrete thought, and the pain of the depot shot was more important to her than preventing pregnancy. But yet, when they get more developed and develops formal operation through usually trial and error, they may have already had a pregnancy, then they realize, I better take this painful shot so that I can prevent pregnancy. But it's also taking medicines. They'd rather stay out with friends. Well, we took care of a lot of folks with spina bifida. They had to self-cath, and when they wouldn't want to do that when they were out with friends. It was more important to just hang with friends than to do their self-management, and they would get in trouble because of that. And you would see them basically not deal with that until they became intellectually more future-oriented and be able to understand the consequences. There are family barriers, too. A lot of families are really protective of their youth. And when you start to promote independence during this phase, there is risk involved. There's risks that they will fail. There's risks that they will go off their medicine if they're given that responsibility. And we've worked with a lot of parents to try and take little steps to enable youth to have more independence, more responsibility. And we talk about what's the potential risk, what could happen if they didn't do it. But you got to let them do it, because 10 years from now, they're going to be out of the house and you won't have any input on it. So let's help them develop the the sense of responsibility of taking their medicines and going to clinics. And we would actually more try and put the responsibility for calling the clinic, reporting side effects, reporting concerns to the youth, and really have the parents move to the side. But that was oftentimes very difficult for them. And parents sometimes had a hard time recognizing that they had youth that were actually more able because they had been smothering or hovering too much. Family cohesion, the youth that are going to, and you see this all the time in mental health, the families that are dysfunctional or having a hard time, the youth is, if they have a particular health problem, they're going to struggle more. And then general poverty creates lots of challenges for youth with trying to emerge from the family life to become an independent adult. Health insurance is changing a lot with the Affordable Care Act. Some of these things have changed, and I'll show you. But generally, there are these cliffs. Medicaid, Tennessee has not expanded Medicaid to poor adults. So if you're 18 and you have a condition that is not sufficiently disabling to qualify for SSI, then you lose your health insurance. Now, there are some stopgap programs like the Title V program and S-CHIP until 19, Title V. Sometimes you can carry people along. But if you're poor, your family's poor, when you're 18, you don't get your family's insurance. Again, the Affordable Care Act has allowed more adolescents to become insured under their parents' insurance, but that's only the private insurance. It doesn't apply to Medicaid. If you're on SSI as a young person, when you hit 18, how many people know that you're redetermined at 18? Do people know about SSI redetermination? Some nods. In childhood, SSI is determined based on a functional assessment, significant impairment in 2 life areas. In adulthood, it's based on your ability to work. It's a completely different metric. So about 30 to 40% of youth who have SSI as a child will lose it as an adult. And once you lose it, how long does it take to get back? I've had youth who've had IQs in the 50s, and they got kicked off of SSI. And we worked to get them on. We worked with legal aid to get them back on, but it can take 18 months, 2 years to get back onto SSI. It's a very long process. So the importance of SSI is if you have SSI and you keep it, as an adult, you keep Medicaid. If you don't keep your SSI, you don't keep your Medicaid. Those two are linked. And there's lots of cost barriers. As you know, the kinds of medicines that you're prescribing are very expensive. And if people lose their insurance, it's going to be very unlikely that they'll continue them. This is a slide a little bit out of date. It's 2013, but this is showing the percent of youth that are uninsured either all of the year or part of the year. But the bottom line is with the Affordable Care Act and expanding the ability of youth to stay on their parents' insurance. It used to be to stay on your parents' insurance after you're 18, you had to be enrolled in school full-time or disabled and fully dependent on your parents. But the Affordable Care Act said, no, up to 26, any youth can stay on their parents' insurance. The parent has to pay for that insurance, so that's a barrier. But it has enabled millions of youth to get on, keep their insurance, so that's been very helpful. And one of the barriers we just throw out there is that pediatric care, child, adolescent, mental health services is very different than adult services. So it's the culture of the service. Pediatrics and child health services are more family-oriented. I think they're more nurturing, maybe more tolerant of bad behavior like lack of compliance and things, whereas the adult system is a little more cognitively oriented, a little more certainly one-to-one patient. Parents are cut out, and that's a big issue for youth that have intellectual disabilities. Their families might be cut out of the medical decision-making, even though the youth may have limited decision-making ability. And that's one of the things I'll mention later is, again, during this stage of life, when you hit 18, you're a legal adult. It doesn't matter what your IQ is. It doesn't matter how disabled you are. It doesn't matter how able or unable you are to make decisions. Unless you go through a process of medical decision, a surrogate or guardianship, you're responsible for your own decisions. So crossing this divide causes a lot of consternation for parents who want to stay involved in their children's health care and mental health. We looked for studies about adult psychiatry, kind of willingness, receptivity, feeling comfortable with some of the conditions that arise in childhood, like ODD or ADHD. We couldn't find those studies. We couldn't find any studies. There are a number of studies now, and they're expanding, looking at adult service providers and their comfort level with conditions that arise in childhood. This is internist. This one's on internist. It was done in New Hampshire. And it was just a list of conditions here. You can see blue is comfortable, yellow is uncomfortable. And so they were comfortable with, kind of basic things, but stuff that has, chromosomal metabolic disorders, technology-dependent CF, autism, cerebral palsy, spina bifida, they were not very comfortable with these conditions. I don't know if there's a kind of similar thing in psychiatry where how comfortable are adult psychiatrists taking care of some of these conditions that are primarily arise in childhood or more developmental. I don't know. I just raised this. Internists were surveyed. Why didn't they want to take the youth with special health care needs, these youth with conditions? And you can read the reasons. I mean, it's basically they're more involved. Many of them are on Medicaid. They don't have the care coordination support to connect these folks to the services they need. And a lot of times they're very super specialized. Imagine a child with a genetic condition that has intellectual disability and a co-occurring mental health disorder. How many providers do you think are going to be interested in that person? I mean, and there are a lot of them. That Down syndrome, the neurocutaneous disorders. There's lots of these disorders that in pediatrics we've kind of organized services for them. We may have psychology with our, specialty care, and then they go into adult care. And where do they get care? We don't have really well organized services to take care of a number of these. I was talking to a geneticist in Miami, and she's following like 3,000 patients with neurofibromatosis, 1 and 2. And they have a lot of mental health issues as well as a lot of physical health issues. And she's a pediatric geneticist, and she's following people into their 50s and 60s because she can't find doctors that are willing to take these patients. So there's a significant problem in the training. The other thing, though, this is a national survey of parents, youth with special needs, basically asking, did your pediatrician prepare you? Did they talk about the fact that care is going to change when you go to adult provider? Did they talk about the needs that might change when you become adult? And a lot of conditions that the healthcare needs do change as they get older. Pediatricians, we're not very good at doing either of these because we don't know much about what happens in adult care. So only 40% discuss these things, even things around health insurance. We don't warn people about what's going to happen. There's a lot of, and I'll go quickly into some resources, more and more resources to help pediatricians, family physicians know how to counsel families that may have a child with a very significant health problem, what's going to happen when they become an adult, and how can we prepare you to be ready for that. If they had a medical home, they're more likely to get this kind of counseling. Obviously, that makes sense. Okay. This is one of my patients. That's a picture of a person with Down syndrome, but the patient that I quoted actually had spastic quadriplegic cerebral palsy. And she left pediatric care and wandered around for like 4 years in the Jacksonville area until she found our clinic. And we knew how to plug her into adult care. My partner was an internist, we used to give talks to the adult providers on how to care for the young adult with cerebral palsy or Down syndrome or these other things. So there's a lot of training that's needed, but the systems are not in place. This is one of my favorite Larson cartoons. Anyway, do psychiatrists laugh very much? I don't know. Okay, sorry. When you think about transition, you're really trying to, there's a number of moving parts, and I want to just kind of help you think about the model that goes through my head. There really is, medical care is going to change from pediatric to adult. Insurance is going to change a lot. They need to take responsibility for their own care. They need to become independent. And there's going to be a lot of other life things going on, which I think in psychiatry you guys are very good about thinking about their education, vocation. We would actually do a questionnaire about their educational and housing and living goals, because if we could support those, that would motivate them to be more adherent with their health care and be more engaged in learning how to become independent. And the message that we had was that the more independent you are with your health care and health, the better you can pursue your goals in life with your education or vocation or romantic relationships or whatever. I like this slide just because it's from Great Britain, but it just shows that during transition there's a diminishing role of the family, an increasing role of the youth. There should be a lot of communication between adult and pediatric services, and this does happen in some settings, and I'll show you some. This is another way I like to think about it, is if you look at the population, again, this applies to almost any condition in pediatrics. If you look at the population, there's a lot that don't need a whole lot when they transfer. They just need some information. They need a referral. They're very independent. They have a supportive family, etc. And they have a mild disease. But the more complicated the condition, the more dysfunctional the social setting, the more support they need, then they're, pardon me, I'm getting over a cold. There is this group, in pediatrics it's probably about 5 to 10% that may have physical health conditions or mental health conditions that need a lot of support during this phase of their life in order to get into adulthood without ending up in jail or killing themselves. This is a little diagram. I like thinking about things, but this transition is a combination of services that are self-management, chronic disease services, really accessing and changing healthcare systems, and adolescent and young adult, and the typical adolescent young adult, either mental health or general health services, which you can see some of the things that are part of that. So how can we improve this? This says it's time we face reality, my friends. We're not exactly rocket scientists. This is my favorite, Larsa Kent. Sometimes I feel this way when we're taking on new projects, that we're not exactly blank. So there is some evidence in mental health services for transition programs. It's not rigorous evidence. There's no randomized controlled trials. There was a systematic review published, and you can see the references down there. But the basic, they looked at 19 studies. Again, it wasn't great quality evidence. But the basic conclusions from them are, during transition, we need to tackle stigma and somehow reduce that. Give them age-appropriate services. There's lots of interesting examples out there where youth can come into a situation like a after-school program or a day program and be with other youth, be with service providers trained to deal with youth, because during this age group, they're not going to fit into the adult system. So part of the message is we need to create a system that's youth-friendly. Parents want to be more involved, and somehow we need to help them be more involved. And that can be very complicated because the youth cannot want their parent to be involved. And I found that the youth that don't want their parents involved are the youth that really need their parents to be involved. So a lot of times I'm brokering with them. I'm saying, hey, I get this, but I think we really need to include your mom or dad in this. Let's talk about it. And so I think trying to really include parents in a way that doesn't undermine the youth's responsibility. They found that the transition care was very patchy and often not prioritized within mental health. And this is not just true of mental health. A lot of kids with very serious chronic illness, typically the transition approach by the pediatric provider is to say, hey, this is your last visit with us. Here's some adult gastroenterologists. Here's some adult endocrinologists. Bye. That's often transition. So the fact that they didn't prioritize it in mental health is very consistent with healthcare in general. And there's no particular model that's been proven. There are state programs available to help youth with mental health conditions. Some of them are embedded in foster care. Some of them are related to juvenile justice and the courts, DCS. There are not many that I'm aware of that are independent of those service delivery systems. So basically we require a youth to pretty much fail before we intervene. That's pretty much it. This was an interesting program in San Diego. You can see they had big numbers. This is a cohort study, 931 in the youth-specific program, and then the adult program is 1,500. What they did was basically create a youth-friendly environment where they had counselors trained specifically to work with youth. They did a lot of work with youth in goal setting, engaging them in community activities, getting mentors, getting them to help with employment training or educational training, vocational training. So it was more than just mental health services. And I don't know, is this yeah. So what they found was, you can see it's significant, was that they basically increased service delivery. This is number of visits per year as compared to the adult system. They also decreased slightly emergency room visits. That's it. But, I haven't seen any studies that look at actual mental health outcomes, more service delivery outcomes. But this is kind of the design. If we could design a youth-friendly system, these are kind of the elements. I've already gone over some of them. It's a place where the youth can feel comfortable, a place they call their own. It's different from the adult mental health system that That's the abbreviation for adult mental health system. You know, staffing that maximizes engagement in, not just engagement around their mental health condition, but engagement around life in general. Again, reducing stigma, a lot of peer support. Working on strengths, obviously you guys know about this, focusing on strengths and trying to enhance those strengths. Employment was a big part, and housing. So these are mental health systems that are really more comprehensive than just clinical care. There are examples of transition programs in other areas, other clinical areas. There's a few here. There's one at UNC for Down syndrome program, special nephrology program, epilepsy program. We had a general primary care program. These are primary care programs. There's specialty. There's a number of programs for kids with congenital heart disease, but they're kind of scattered. You know, there's any given area of the country, there may not be much for transitioning youth. And I have to say that mental health services, specifically for transition, I've seen some examples. There's a TIP program that was started in Florida and tested in a few communities. They've been generally grant funded. The systems of care grants, are you familiar? People are familiar with systems of care grants. They have often focused on youth, trying to prevent residential treatment by offering lots of wraparound services. But those are oftentimes grant funded and they go away when the grants. So we don't have a great transition system in mental health care in this country that I'm familiar with. There are some other programs and just general kind of ways to help support youth during transition. I'm not going to read this, it's very busy, but the Got Transition on the website will be at the end of the presentation, has a lot of tools to talk about youth, and I think many of them could be adapted to your youth in your clinical programs, really warning them about what's coming, telling them they're going to have to transition to adulthood, helping them create a care plan or get ready, and really help find a good fit into the adult system. So the pediatric or child-serving system really has to do a lot of work to get them ready and plug them in. And this is kind of for clinics, this is really primary care, but it could be adapted, and you can see some of the things that are recommended. They really recommend for youth with complex conditions, this wouldn't be all youth with mental health, but maybe youth with significant mental health conditions, that they have a transition plan, which really allows them to know what their condition is, to have key history elements summarized, to have input from all the disciplines, and that it really, this is for one provider to hand to the next provider. So you're really basically telling the story of this youth so that when the new provider takes over, they're not starting from scratch. It's a lot easier. So this is, I just threw it together, some things that I think should be, if you're going to transition a youth to an adult provider, they should get a summary of that youth's history. And you can see all the things on there that might be relevant. And this is honestly, there's a number of transition care plans that have been developed in epilepsy and other conditions, and I kind of adapted it to mental health. But I haven't seen anything like this, but I'm sure that when the handouts happen, sometimes this does happen, sometimes it doesn't happen. But if we could make this a standard for all youth aging out, that they get this kind of big summary, and they should have input to it, but then they take it to their adult provider. It would help the adult providers take over their care. This is more parts of the medical summary, social, significant medical conditions as well, and their treatments, social history, and life goals. So there's some supports for families. I mean, I have like 5 minutes. This says, shoot, you not only got the wrong planet, you got the wrong solar system. I mean, a wrong planet I can understand, but the whole solar system? Anyway. So there's a lot of toolkits that families can access. This is an autism toolkit. I couldn't find any mental health specific toolkits, but this really goes through, has the family go through and prepare with the youth how to get ready to be independent and be in the adult world. And it raises a lot of issues like legal matters, housing, post-secondary education. What's going to happen to this youth? And it gets the youth and the family talking and making plans, rather than just no plans. There's a lot of material on websites. I'll give you 2 websites at the end that have information about SSI, which is very important. There's been lots of materials put out about, kind of get your families thinking about transition. This is from the one that I worked on, and has just basically, family here, start early. Get the youth to take responsibility for their own health care. Get a health care summary so everybody knows what's going on. Just do some of these things so that when the handoff happens, you're ready, you're prepared. And again, there's lots of materials that have been developed. I haven't seen tons on mental health, but they could be adapted. This is one we put together in Florida. We've done it every year. There's a 2015 version, but it's all about health insurance during this adolescent young adult period and what options there are for health insurance, to maintain your health insurance. And that's even this is Florida specific, but most of the health insurance issues are national, but there are even some state specific programs that you could look at this and say, oh, maybe we have something like that in Tennessee. But insurance is very complicated. This has been downloaded tens of thousands of times. People really struggle with health insurance during this young adult period. Again, there's lots of material on medical decision making, guardianship, and most of this is very patient friendly. It helps the family and the youth sit down and decide what level of help do they need for medical decision making. And again, it's much better to do this before 18, because once they cross over into 18, if something bad happens and you have a person who really can't make decisions, then the healthcare system may not serve them very well. This one is just shows levels of guardianship and the restricted levels from durable power of attorney to plenary or full guardianship. Full guardianship, which is oftentimes needed for people with intellectual disabilities. Anybody know how much it costs for a parent to become the guardian of their child at 18? Anybody want to guess? Yeah, $4,000 to $5,000. That's to go through the courts. So, and think about the families that have youth with significant mental health disorders or disabilities. They tend to be poor. So $4,000 to $5,000 is a big nut to crack. We had a very great partnership with legal aid. So we would refer them to legal aid, and legal aid would help them get guardianship at a very reduced rate. But it's a very important thing to think about. So one last thing I'll talk about is, one of the things I got very interested in is how do you measure people's readiness for transition? How do you know that they're acquiring these skills that they need? And you can see the different categories of skills up there. How do you, so we developed the tool, and we've tested it, validated it, we've actually published on it, and a lot of groups are now using this tool. It's called the Transition Readiness Assessment Questionnaire Track. And they're simple questions like, do you fill a prescription when you need to? Do you know what to do if you're going to have a bad reaction to your medicine? And we have these categories which are really the stages of change. No, I don't know how to. No, I don't know how to, which kind of is pre-contemplation. I don't know how, and don't bother me with it. I'm not ready to even think about it. Up to, yes, I always do this when I need to. And we would give this to youth in our clinic. We're still giving it to youth. It's in the medical record now. And we would counsel them and make goals based on their level of readiness for acquiring these skills. So one can work with youth and families so that they're ready when they have to. And again, there's more materials on teaching youth to be an advocate for themselves in the healthcare system. This is a really cool acronym developed by a colleague in Florida called GLAAD, and it teaches youth how to interact with a healthcare provider. They're oftentimes very intimidated. They don't ask the questions. They leave. They're confused, and then they don't do what you ask them to do. So part of this is to get them to be more part of the partnership in the education. But there's lots of stuff. There's lots of other materials that I'll just zip through here. Got here. Actually, one last thing is, lots of times the care plan that the patient has is very useful. And we develop these care plans. Now you can do it through Allscripts or Epic or these electronic medical records. By putting everything down on paper, I was always shocked that families didn't realize what medicines they were taking, or what all the different specialists we were expecting them to go to. But just listing all these things down, it also was a very nice thing to take into the emergency room so they can see what's going on if they don't have access to electronic medical records. So that's one of the things that's happening in transition that's helpful. This is an example of kind of a youth-oriented transition, a passport where they fill it out. Okay, these are two websites that have a lot of materials that are helpful in transition, education for parents and education for providers. And that's my last slide. Thank you very much. We only got like 3 minutes, I'm sorry, but any questions? Yes, ma'am. Uh-huh.
One of the things I've learned is from cognitive conditions when they receive that particular child is they've agreed to like continue and if they're local, continue to provide that assistance for them until they finish college and then after that comes it's that condition to see the difficult physical in the age of adjustment of college. Plus with all this sensitivity about substance use and testing and whatever. And if it's from the nose, it changes that having that continuity so they can finish college might make sense in class.
Absolutely. You know, in pediatrics, we're debating about how long we should be responsible. And I advocate for a higher age. We're advocating for the physiologic changes between 19 and 23 are not, there's not that, nowhere near what they are between 12 and 15. But so I agree with you that that's very helpful if the person prescribing meds could keep them going through college. In many colleges, have their own insurances or they have student health services. They will not prescribe Schedule II substances. They just won't do it. My son went to college. He had ADHD. He was on meds, and his pediatrician refused to do that. Actually, it was a psychiatrist. And so we really said to him, you got to find a psychiatrist in that region. And he did. He found one. And we said, well, if you don't find one, you're not going to get medicine. But it was a hard transition. It was kind of like that, and that wasn't good. So there are some things that our child health serving system could do, especially during these times of defined college, that could be very helpful. Colleges are really getting hammered with youth that have tremendous health and mental health conditions. And they're coming in, psychotropic meds and physical disabilities, and they're coming into college. And the student health services are kind of reeling and trying to figure out how to deal with. So there usually is an Office of Disability in college that will create accommodations. And I've found, working with a couple of colleges, that if a youth comes in there and needs medicines that the student health services won't deal with, that the Office on Disability will help them. Once you go into college and leave high school, IDEA is done. You have no more legal rights for an education, accommodation in education. But most universities are trying to accommodate this new group of students coming in, and they will oftentimes try and find them health services that can help them if they have special needs. Right, which is another good reason for having parental involvement to some degree. Great. Yes, sir.
The department is actually supporting that aspect of trying to help with transition in terms of mental health care with the student counseling center and student health center. And I'm directly involved, I sometimes promote that. But I think that despite the fact that that's a focus that can be taken, and it's one that hopefully with more college students now than in years past is even more impactful, we obviously need something that's a much grander scale than that. And one of my concerns is that we're not very good about transition generally, even in terms of shifting providers within primary care, pediatrics, or adult internal medicine care. And I think that this is a continuum of difficulties we have with transition, and that the mental health area is no exception in terms of the issue of difficulty in transition from child and adolescent psychiatry to adult psychiatry. So we really need to try to address that along with the larger picture of transition.
And I think a component here, which is, under the Affordable Care Act too, these things are happening, is care coordination. I mean, care coordination, I've given a lot of talks on transition. Some physicians are very empathetic and feel it's part of their responsibility to help this transition. Some feel like, hey, I'm a pediatric provider, I'm kind of done. But generally speaking, the folks providing coordination of services like nurses or social workers or others, they will really see the need to do that and will help enhance the handoffs and the coordination. And if someone falls through the cracks, they'll try and get them plugged back in. So I think a lot of it can be built on kind of nursing or social work care coordination, which can be very helpful. But I think one of the big things too is we don't really, if we have this new stage of life, which is like emerging adulthood, and we don't really have a health system that's that's very receptive for them. I mean, it's not focused on their needs. We have one that's maybe child-friendly, we may have one that's adult-oriented, but there is this group it's getting bigger. And so it's something to think about, like having a more comprehensive, youth-friendly approach that they can transition into until they get more stable and go into adult system is one of the ways to think about it. Great. Any other? Thank you very much.